Hey everyone, just a quick lead in to the following conversation that I had with David Shifrin for his Health Further podcast. We are publishing this both on his platform and my platform here on YouTube, and hope you enjoy the following conversation related to healthcare and innovation and the future. Thanks.
Hey, Chris Chan, it's good to talk to you, man.
Yeah, you too. Good to see you on video as well.
Yeah. So, so I'm just going to start this by saying that, actually, well, will I? I don't know. I'm going to go ahead and start and say that Chris and I have been working on this for a while now, and by a while I mean like the last hour and a half. Not scheduling the interview, but getting the internet to not suck for us. And I think we now have at least two, possibly three systems running simultaneously, and we'll see if they're compatible. So this is fun. Chris, thanks for taking the time.
Thanks for having me. And, I got to say, the first time we did this, I think we were both brilliant. So we're going to have to try to reach that same gold standard that we achieved before.
It's no pressure at all. And I was really good because this is the first time that I've ever done video. So I was thoughtful while also managing to not look too stupid on camera. I don't know. We'll see. This is Chris Chan. For my audience, a lot of you may know him. He's been involved with Health Further before. He's spoken, been on some of our promo videos. And I emailed Chris, a few weeks ago and said, look, man, I want to get some different people on the podcast. We need some different voices. What will it take to convince you to guest host for us? And Chris wrote right back and was like, hey, sounds fun. Let's do it. There was no convincing. It was way too easy. So Chris Chan, formerly of Mercer, now a free agent in life, building all kinds of wild stuff in his basement lair. Thanks for being so chill and jumping into this thing.
Yeah, thanks for having me. Just trying to do fun, creative things, and stuff like this is a no-brainer because you always learn stuff along the way, having interesting conversations.
Yeah, all the good ideas come out of the random stuff in life. Okay, so you just said creativity. You're trying to do interesting stuff. I think you're pretty interesting. You do innovation, you do art, you do content production. Your LinkedIn profile has comparisons to David Blaine, James Bond, and Don Draper. You wrote an article about the NBA and what that can teach different companies. You're a tattoo artist. I got to ask, man, are you the most interesting person in healthcare today?
I try, but I'll leave that judgment for others around, whether or not that label is appropriate or not. I should caveat the David Blaine, James Bond, Don Draper. Those are all things other people have said to me about me, and so I didn't create those labels myself, but I do appreciate them. I think in a lot of ways they're appropriate, and my main goal is to be authentic and genuine and cut through the noise and just try to offer a fresh take, a new perspective. I think there's a lot of new unconventional wisdom that needs to be shared around to help push past a lot of the barriers and moats that have been created in this space. And so that's part of my job that I see to help cut through that.
Yeah, I mean, I asked the question sort of jokingly, but I think it's also a real question because this whole thing around authenticity and being interesting and, being a tattoo artist in healthcare, whatever combination of kind of fun things you want to talk about is useful because the way that I sort of oversimplify it and think about it is that we've got an industry with a lot of suits and ties who, in one way or another, recognize that the industry is changing, that the old models aren't going to work. And I think in most cases, those people wearing the suits and ties know that, and they go home at night and they recognize that they've got to be innovative and try cool new things, and they want to, and they want to be out there, whatever, mountain biking and kayaking and coming up with something awesome. And a lot of them do, but they're sort of constrained by the industry in which we all work, this mammoth of healthcare that's just very hard. It's a big ship to turn. I'm just going to start mixing metaphors here. So figuring out how to break through that and kind of engage people on a personal level and help them figure out how they can turn the ship is a big deal. And so that's one of the big reasons why I'm interested to talk to you.
Yeah, for sure. I mean, your suit and tie comment, it reminds me of a story for another day when I wore a pink suit to a healthcare conference, and I stood out like a sore thumb. And so maybe bonus content for another audio clip. But I think, just having an authentic, genuine voice that is going to rub some people the wrong way in commenting and observing some of the trends and themes that are occurring within this ecosystem, because you have a lot of stakeholders that are invested in the tried and true mechanisms for making money and setting up barriers and walls, restricting access to information and making it harder for people to get whatever service they need because they can make money off of it. For better or worse, there's money to be made and stakeholders to report to and beds to fill. And so got to figure out a way to maximize profitability, unfortunately. And so at the expense of customers, employers, patients a lot of the times. And so how do you rebalance some of that equation by just calling out some of the truths that I see in this industry that need some light shine on?
Yeah, and it's one of those things where in any industry, you're going to have a few people who are genuinely malicious, but that's not even really what we're talking about here. The realities of running a huge company in a 3 trillion dollar industry are tough. It's the tyranny of the urgent. And so you've got shareholders to report to or profit margins to try to deal with. And so on a day-to-day basis, just figuring out how to do all this is really difficult because you got to we'll stick with the ship metaphor, right? You got to keep it floating. And so, I know what you're interested in. What I'm interested in is figuring out how we can kind of look down the road a little bit and start to help people do a little bit more of the long-term planning and think about ways to shift on a large scale into what we had helped further anyway see as being kind of the new healthcare economy. So that's the first thing. And then the other thing that I want to point out is, you're talking about what that means in practice for individuals around obscuring information and just making it difficult for people across the board to navigate. And I think the example there is the price transparency thing that CMS just put out, and they're saying, look, you have to put your prices online. And so all the providers, again, they're, for better or for worse, whatever reasons might be, whatever the motives might be, they, for the most part, kind of took the minimum step and said, all right, here's our charge master. Good luck, everybody. And it's useless information. We got to be able to figure out how to make that more useful because it's good for patients, but ultimately I do think in kind of a more consumer-driven market, it's going to be a lot better for the providers as well.
Yeah, I think that's part of I like to think we're in the cusp of a golden age in healthcare and really using technology to transform how services are purchased and the information that's available and being able to scrape through 6,000 pages of a charge master to really what's relevant and make some insights and build some indices to compare one system versus another, to have some apples to apples comparison around what real costs are within the system. And so right now, being a free agent, I've been able to spend a lot of my time with interesting entrepreneurs and innovators out in the space trying to make some of this change happen. And a few of them are on the financial payment side and scraping data, whether it's on charge masters or publicly filed reports that nonprofits have to disclose, and just looking at profitability and asset growth and the accumulation of billions of dollars over the last 4-year time frame. You look at any geography at healthcare, and there's tremendous money being collected on the part of health systems at the expense of patients and employers in a lot of cases. And so it feels like there's greater opportunity to put some of that information in the customer's hands to say, hey, this doesn't feel right. This doesn't sit right with us. You're making a lot of money, and certainly not to cast dispersions on the entire industry, but if there are a few bad apples playing on some of these levers to exploit them, it's like, okay, how can we actually point this out and have a different type of conversation around what's appropriate to charge?
Yeah, so how do you push through those incentives? So again, you have the bad actors who are just malicious. And then you have the just the sclerosis of tradition, and then you have again kind of the tyranny of the urgent, having to look at other things and okay, we have to check this box for regulatory purposes, but we don't have time to deal with that now. So how do you start to change the conversation around what information should be put out there and how you manage it to the benefit of the patients?
Sure, certainly. So my hope is that the employer customer becomes more sophisticated and starts using their leverage to greater degree. And I'll say, the last couple months, I've been sending emails and notes to handfuls of employers out, just pointing out some of these observations of local health systems and what's going on in their geography. And not to blame the current state of employers, but I don't think they're used to doing something with that information. And so let's say out of 30 notes that I sent out, I heard back from 10%, and maybe, so that's 3 out of 30, and maybe one of that 3 was like, oh, this is really interesting, we could do something out of it. And the rest, I think, they're just inundated with so much inbound noise from all the solutions that are out there in the market trying to get their attention that they can't cut through and say, oh, what Chris is sending is really different. And maybe it is, maybe it's not, but there's just so much other stuff to try to process out there that, it's just overwhelming choice, and that leads to inaction. And so, they're just trying to do the best they can and bite off what they can. And it's like, well, we rely on our health plan, our carrier who negotiates these contracts. We rely on them to do that. So, it's worth my time to spend efforts elsewhere, perhaps.
What are those efforts, though? Because employers are trying to shift costs back, which is why high deductible health plans are on the rise. And I think that is a net good, because in time that's going to force us as individuals to act as consumers, right? If we go from a $1,500 deductible to a $10,000 deductible, in theory at least, data is unclear at this point, but in theory at least we're going to start to think more carefully about our healthcare choices. Why isn't it in the employers? Why are 29 of the employers kind of putting you off? If you mentioned the noise, the overwhelming volume of stuff they're trying to look at, but they know they have to do this. So what's going on?
Yeah, well, I think there were a few buckets from the research that I did at Mercer, and over a 4-year time frame, we evaluated 600 companies out in the space, all new emerging digital health startups trying to sell into the employer space. And so there were a few buckets that those fell into. One was certainly condition focused, so musculoskeletal, behavioral health, cancer, cardiovascular, women's health, or family forming. Those top 5 categories are going to be in every employer's top 10 in one order or another. Those areas show up, and those are high dollar line items that during a annual report with a health plan reviewing the past year's claims, it's like, okay, these are identifiable cases that we know they're going to happen next year. Somewhat. We don't necessarily know who. We can do some risk modeling and predictive modeling, but we know that this frequency in these areas is going to happen. So that's the first bucket. And a lot of employers have focused on interventions and partnering with some of these startups that focus in on those specific areas. It's an easy place to start. The second bucket is what I call all the things that happen in the pipes. It's the financial systems. So out-of-network charges, subrogation, reference-based pricing, bundled payments, narrow networks, payment integrity, fraud, waste, and abuse. It's a whole jumble of new terminology, and it's the payments that are flowing through in the pipes. And yes, we want to steer people to high quality, and maybe we'll narrow networks to help achieve that. But just a lot of the payment processes are broken behind the scenes. And unfortunately, if you peel back the covers, a lot of the things that are charged incorrectly, they go in the favor of the health the provider, right? And there were instances where we saw providers submitting the same incorrect charge over and over and over again, tenfold, and it got rejected 9 times, and for whatever reason, the 10th time it went through. And the provider got what they wanted at the end of the day. And so, it's just flagging a lot of that stuff that's inherently broken. And so that second part really fascinates me. And then just quickly, the third bucket that we researched was just all the crazy wild ideas out there, whether it's blockchain or virtual assistants, artificial intelligence, drones, every buzzword imaginable that's funding the next new startup. That was that third bucket. And maybe it'll hit healthcare in, 6 years, maybe 10 years.
Yeah, well, we need to have that conversation. That is a separate conversation because there is so much shiny object syndrome going on around AI, and blockchain certainly is kind of having a moment because of the crypto markets, but that's another area, and so let's have that conversation soon as well. But I want to go back to the payment, the stuff going on with payments. And first of all, you talked about the 9 out of 10 rejections, and then on that 10th one, they finally paid up. And it's funny because you talk to the revenue cycle people at these providers, and they're saying, I'm just struggling with denials, and it costs so much to get my team on these denials, and we need that money because we're delivering the care. And so that's just an example of gaps in the system where every side is convinced that they're right. And even the fact that we have sides in this discussion,
right,
because it's a financial transaction, is a bummer. But it is kind of funny to hear you say on the payer side, no, quit sending this claim. It's wrong. And they're saying, please give me this money. It's right, for whatever that's worth. But the other thing, going back to the kind of the financial piece of it, the pipeline that you're talking about, I've been working off of this idea for the last couple of months that better patient engagement and education around just the finances of healthcare are going to be really important, not just for patient experience, but also for the underlying business. And this goes back somewhat to what I just said about high deductible plans and HSAs. And again, you talk to the revenue cycle people, and they're saying it's so expensive for me to pursue a $100 bill, a $200 bill. Either these small claims are just brutal because they cost $50 in time and resources to collect. So I'm working on this idea that if healthcare operated more like other industries, where you walk in and you say, okay, your new iPhone is going to cost $800, or in this case, hello, welcome to Verizon. It's going to cost you $30 a month for 24 months. This is what you expect to pay. And you may think it's overpriced. This is badly overpriced, but I'm paying my $31 a month, and there you go. You don't do that in healthcare, right? And so if you're not coming in expecting to be responsible for $200, you're less likely to pay, and then everybody has to fight that battle. So what's your take on that? How does that play into this whole transactional pipeline that you've mentioned?
Yeah, certainly. So I'll give you an example. There was a company we came across. They're called Simplicity, and they look at all the EOBs and the bills that patients receive on a regular basis. And if you have a significant episode of care, it's a lot of paperwork that you're sorting through, and you're trying to figure out what your patient responsibility is. And they said, well, let's consolidate all that together, and let's make it one statement that you get once a month, like your credit card bill. And let's show you what your balance is for that month, and you can pay it off in full, or you can pay it off a fraction, 1/12, and you pay off 1/12 for the next 12 months, and they've essentially extended you an interest-free line of credit. As long as you pay off your minimum, they'll give you a year to pay it off, which sounds great for the patient. It's like, why wouldn't they do that? And then you're like, well, how do they pay for that risk? Because they're floating the money of that patient responsibility in the meantime, because the provider's not going to be willing to take 1/12 every month, right? So what Simplicity has done and said, well, provider, we're going to pay you up front. We're going to pay you within 7 to 10 days, all at once. So we're increasing speed of payment for you. And in return for that, and we're guaranteeing that payment at the same time so that it doesn't have to go to collections where you get 10 cents on the dollar. In return for speeding up your payment, you give us a portion of that, a few percentage points, and that's our fee. And providers overwhelmingly seem willing to accept that because they're like, yeah, we don't want to deal with all that administrative back and forth and that lost revenue that extends out with time. And so, yeah, give us our money sooner. So that was an idea that we came across and we're like, well, that's brilliant. It makes sense for providers. It makes sense for patients. And it's no cost to employers. They were offering the service for free to employers. So it's a win-win-win. Why doesn't this exist universally? And part of the challenge, right? Part of the challenge is the health plans do a lot of those functions today in processing the EOBs and the statements, and they're in the claim stream. And so you're battling against existing infrastructure. And so entities like Simplicity turn to TPAs. It's like, okay, the TPA is just handling the adjudication and the contracts on the back end, and then the members-facing stuff flows through this new entity instead of the health plan. So it'll take time, but that was a no-brainer idea that just felt like should exist universally.
Yeah, another one. I'm not sure if it's the exact same model, but another that sounds very similar is care payment. I was talking to somebody recently from over there, and it's same thing, kind of 0% interest loans, and they float the provider money and they take some kind of cut, is my understanding of their model. And again, I look at that and I go, why? Where have you been all my life?
Right. And I would talk about these ideas with our health system clients who were employers and providers in a community, and their HR teams would be like, why can't we do this? We should be able to build a system like this that simplifies the experience for our patients. And that's really, I think, the change that we should all be working towards, whether it's Simplicity or care payments or the health system itself. Someone should be reimagining the equation for payment processes and helping make it a win-win-win for everyone involved.
Yeah, and that's a great point, Chris, because you look at the large providers, the large systems, as you said, as providers, they are also large employers, and so they have a pretty significant patient population in which they can experiment with things, which is cool. I don't know how much of that is really happening, but then that brings up the obvious point of the new Amazon, Berkshire Hathaway, JP Morgan venture, which we can finally abbreviate, or not abbreviate, but we have a name. So Haven, that's what they're doing, and that, as far as I can tell, is basically their approach. Look, we have a massive population in terms of employees, hundreds of thousands or millions, and Walmart's another place, they've got 3 million employees. I'm saying, look, it's too expensive for us, so we're going to build our own thing. And I think it's both an interesting example and, we'll see how it all plays out, but largely a positive example of what innovation could look like in healthcare. And so providers should be looking at that, but it's also, I'm sure, very scary because now you see these companies who are known for being disruptive coming in and saying, look, you guys aren't doing it right. We're going to figure it out on our own. And if we have to go through you or around you, we will. And I've seen some quotes from Haven saying, look, we're only doing this because we have to, and we would rather partner with everybody else, but we'll do what it takes. And so it's kind of an interesting time in that space.
Yeah, I think what we're seeing is a shift, a thematic shift in the industry. And so there's been this long-held concept that every employer at its heart, if they're large enough, they're a little insurance company. If you're self-insured, you're paying for those claims that are incurred within the system. And so you're running a little health plan. You might have a carrier administer and rely on their contracts, but you're on the hook for the financial charges that flow through. So that's the first theme, is like you're a little insurance company. And then the second emerging theme is, well, every employer is part of the health ecosystem in some way. It may be direct to your business or adjacent to, but if you're a recruiting company, you help recruit physicians and clinicians in the healthcare ecosystem. If you're a cloud storage management company, you could sell into healthcare systems as a vertical. If you're a technology company, you're powering the right. So the health is just such a big part of the U.S. economy's GDP that every business is in health in one way or another. So that was the second theme. And then the third theme, I think, alludes to this haven point was, well, if every employer is part of the healthcare ecosystem, every employer could also be an investor to help drive change and be vested to new ideas, whether it's a new business opportunity like Haven or for Walmart. At that magnitude, you're talking about such immense scale that an investor play to build new businesses and adopt some of these new innovations and put them to test for their own employees and then a broader customer base if it works thereafter. That was sort of where we thought things could take shape the best, because the employer is married to the success of that idea taking shape as a business partner within that arrangement.
So that point raises some interesting thoughts, Chris. And let's start with this one, which is like, what does this mean for the traditional providers? How do they need to be thinking about that semantic change with everybody being in healthcare today?
Well, I think first, most obvious, the provider clients who were employer clients of ours, they were the most interesting case studies for us to try to strategize around, because HR within a health system often wanted to be a business partner, or they were being looked upon to test with their employee base and pilot new programs because the system wanted to invest in a new solution or a new piece of technology that they wanted to roll out to their patient community broadly. And so marrying the employee HR side with the business side together and being able to work collaboratively, I think, was a new opportunity that we were seeing start take shape in the most forward-thinking health systems. And so that's certainly one trend. I think as things like value-based care and medical homes and patient-centered care all take shape, and there are penalties at risk for people coming back into the system and having emergency room or inpatient visits and not being compliant, we all know that greater monitoring and coaching and that type of oversight generates adherence. If you feel like you're being watched, you start doing the right things, but that's very costly. You can run the most beautiful study where people check in every day, whether it's in person or over the phone. It's like, wow, we had these amazing results and people were so compliant, but that's not scalable, right? It takes too much labor and that's expensive. And so I think that's the beauty of digital tools, where you feel like you're being monitored, but 90% of the time it's some AI or chatbot or virtual assistant that's programmed to be personable and personalized enough so it feels real. And then the system floats up alerts, and where a clinician can operate at the highest part of their license to say, okay, here's actually a unique circumstance that's occurring, and we think the appropriate response is one of these three things. So we've accelerated the likely decision-making process for you, and you pick the right one and edit as necessary, and then outreach, where it feels like a real human is on the other side to that patient. And so that type of model is what we see taking shape left and right to try and rebalance that feeling of oversight with member engagement.
Yeah, it's funny. I mean, you could have been reading the notes that I was pulling from before we started this call. I was talking with Blake Margraf, who founded ePharmix in St. Louis, and he made the exact same point. He used a lot of the same language around, look, we have to monitor everybody, but we can't. And so what his tools do is essentially automate a lot of that. And then when something needs to be flagged, it's flagged. But those interventions that also drive behavior change are huge. And also to the point of practicing at the top of your license. think is another big thing because people are, and I don't really understand why, but there's so much conversation around whether or not AI is going to take over for physicians. And I don't know if that's just because it's an easy talking point or if people are actually scared about that. But I'm like, it's just not, it's not happening. So let's focus on what AI or whatever version of it you want to use can do, which is to highlight the important information and bring the useful stuff to the top.
Yeah, I think about all the boring, non-value added processes that we have humans acting as glue between various systems or helping close the gap around patient flow and outreach. And it's like there's a lot of administration happening within the system. It's not the clinical judgment stuff. It's just the basic blocking and tackling boring stuff that we still have a lot of labor being put to task to. And so how do you free up those resources and build robotic process automation around that to help eliminate the error rate and the consistency rate, and it can run 24/7 around the boring low level stuff, and then free up resources on the top end?
Yeah. Okay. So Chris, let's kind of look at where you hope things go over the next few years, like wrapping all this together. And I want to take this again from kind of the entrepreneurial innovation side, and then also from the healthcare system and employer side. So the incumbents and the disruptors. What what do you want the healthcare system to look like in, let's say, 2 and 5 years? Don't worry about the alarm going off in the office next door. Everything's fine.
Yeah.
So if you can hear that.
So, 2 to 5 years, it's not a lot of time. I think we often overestimate the amount of change that tends to happen during that course of period. But
Yeah, so actually let me stop you there because you're right. And I screwed that question up, but I'm changing this conversation on the fly because healthcare has historically been incredibly slow to change. So we are, like 2 years is nothing. That's barely enough time to get a pilot project at a health system up and running. We think that the pace of change is starting to accelerate. Doesn't mean 2 years is going to be, an entire innovation cycle. But first part of that question is, do you think we're right? Is the pace of change accelerating? And then based on your answer to that, I'll leave you to answer the rest of that question.
yeah, I do think the pace of change is accelerating. I think part of it's technology. I was in a hotel last week, and I was people who were watching me would find it funny because I was talking to myself, because I'm used to being surrounded by Alexa and Google Assistant at home, and I was trying to replicate that in the hotel room. And I think, I'm certainly on a fringe of the technology spectrum, but I think more and more people are going to be comfortable with interacting with devices around them in the Internet of Things world that we're going to be rapidly shifting into. And so as people expect that in their home and workplace environment, it's going to carry forward in the healthcare system as well. So that's just one example of new trends that didn't exist 5 years ago, that we're just starting to get more widespread adoption. I think secondly, there's new threats to the existing infrastructure, whether it's Haven or Walmart or some other non-traditional healthcare player coming in and saying, hey, we operate at a certain scale or speed. We might be smaller and scrappier, and we don't have invested interests in the current infrastructure. So we can do things differently than how they've been done before. And so the rest of the system, the incumbents, are needing to respond and say, we're devoting resources to innovation and piloting new things and investing in new startups. And we've certainly seen that over the last 5 years, but that trend should accelerate as well. And then, patients are demanding more. If my deductible is going up and it's already high at $1,500 and you're trying to squeeze blood from a stone and pass more costs on to me, why doesn't this work like Apple or Uber or Amazon, right? I need, in order for me to be a loyal patient here, we're all irrational about the quality of care around us. And yes, outcomes matter, but so does the customer experience, and making me feel like I'm going through a personalized, frictionless buying
Yeah.
experience, because we're all used to that the rest of the world that we live in. And so we're all going to demand more from the system.
Yeah, we're all going to demand more for sure, and we're also going to have more responsibility, right? With great power comes great responsibility. So it's not right for us as patients to just demand that the providers give us the iPhone equivalent of healthcare. I mean, well, I think it is right for us to demand that, but also, then we have to use it well, and we have to be willing to undergo behavior change and not expect to be spoon fed everything, because it's our life. We want our data, we want our health information, we want the doctors to talk to us about our symptoms. It's our stuff, so we got to take responsibility for it. So I think that's the other piece of this that's really important to mention as well.
Yeah, I think it's uncomfortable conversations that patients have been less willing to have with their providers, unless they're going through some very tough clinical journey and they need to take charge. But I think the shifting in financial responsibility is forcing more of these uncomfortable conversations to happen, because the patients are on the hook for higher dollar
Mm-hmm.
amounts, and they're like, okay, I do have to take this more seriously and start to question, do I need to have that test done or go to that referral, or do we kind of already know like what I have, and can we go down a treatment path? So.
Yeah, and the early data, at least, is showing that despite the increased share of spend, patients are not doing that. But we're still early in, like, we're changing society here. We're changing the way both an industry and society as a whole think about healthcare. And so I will be shocked if in the next several years we don't start to see more consumer-like behavior in healthcare. And I hope that's the case. But again, like, it's got to start with me. I have a high deductible health plan and I have an HSA, and we can have this whole conversation. But if I just start blindly wandering around the hospital, not asking questions, then I'm part of the problem.
Well, yeah, I would totally agree with that. I think healthcare is at times boring. It's not that sexy, but it's incredibly personal at the same time. And so, of course, I want the best care. I want to see the right provider. And at a certain point, it doesn't matter what cost it is. After I blow through my deductible and, whatever out of pocket, just send me wherever I need to go. And so that's,
Yep.
I think, a flaw within the current state of high deductible health plans is, once you reach certain thresholds, there's still a lot of costs that can be incurred. And yet the current design for a lot of these plans doesn't have exposure on the patient side. It's designed to protect the patients, but at the same time, it's limiting how much I care. If I'm no longer on the hook, then why should I be as invested in those decisions? Just send
Yeah.
me to the top dollar place.
Yeah. So again, we have to think of ourselves as part of the conversation and not just as transactions, while at the same time we demand that our employers, the payers, and the providers treat us like people and not just transactions. Again, there's plenty of finger pointing to go around.
Right. All sides. Opportunities for everyone on all sides.
For sure. All right, Chris. Well, this has been fun, and I think this redo went pretty well. To be perfectly honest, I still can't think of the point that I was going to make there in the middle, but hey, it worked out. And tell people what you want them to know about you and where they should go to find you.
Yeah, certainly. So if you're at a digital health startup trying to figure out the employer space, brokerage, consulting, channel partnerships, amp up your sales growth, figure out your marketing and branding, and I'm a jack of all trades across all those areas. So spending my time helping a lot of cool, innovative companies figure out those problems. I've started up a company called the Purple Light Idea Factory, which is aimed at advising these new ideas and solutions in the market. So you can find me at chris@plif.us or at theartofchan.com.
Great. And then just remember the really important thing that I have to tease a little bit here. Part of the reason we're having this conversation is because Chris, I think I mentioned at the top, agreed to guest host on this podcast, The Future of Health. And so coming up in the near future, we're going to have at least one, possibly more, conversations between Chris and some really interesting people in healthcare. So look forward to that. And again, Chris, thanks for agreeing to do that, and also for jumping on the call today.
Yeah, for sure. Thanks for having me.
Yeah, man, it's been fun. We'll do it again.
Absolutely. Try this a third time.
Let's do it. And then do we tell the audience? I don't know. Maybe we're transparent and authentic about it.
That's right. This is innovation. This is, you're not going to get things right the first time, maybe not even the second time. You try new things like doing video, and you try to take flight without a backup plan the first time. So that's a good lesson. It's, got to always have backups and fail safes, and third time's a charm, right?
Yeah. This is insert Thomas Edison light bulb 1,000 tries cliche here.
Yeah, I'm sure he got electrocuted a few times.
Yeah, you never hear about that. Yeah. Or his assistants.
That's right. Did. Yeah, for sure.
Okay, now there's my